Good afternoon, everyone. First of all, I would like to thank the organizers for giving me this opportunity. My talk is multimodal imaging in single ventricle palliation. The outline of my talk would be introduction, and I will be discussing some commonly used imaging modalities, their merits and demerits, role of imaging in the interstage, what is the current available evidence, current practice in our unit, and some examples of how imaging was used in few patients. As you all know, the common types of single ventricle which we usually come across are tricuspid atresia, pulmonary atresia with intact septum and significantly hypoplastic right ventricle, unbalanced AV septal defect, double inlet left ventricle, hypoplastic left heart syndrome and its spectrum. Occasionally, we come across patients with large ventricular septal defect where the heart cannot be septated. A little overview on the stages of palliation. The stage 1 usually will depend if there is any systemic outflow tract obstruction or is there a risk of developing a systemic outflow tract obstruction. If the answer is no, then the management will be systemic to pulmonary artery shunt or a ductal stent if there is a restricted pulmonary blood flow, and pulmonary artery band if there is unrestricted pulmonary blood flow. In those patients with hypoplastic left heart and spectrum, the first palliation is Norwood procedure, which involves creating a neo aorta using the pulmonary outflow tract, wherein the native aorta is connected to the neo aorta. And this will also involve arch reconstruction and to secure the pulmonary blood flow, either a systemic to pulmonary artery shunt or a Sano shunt, which is right ventricle to pulmonary artery shunt is performed. The stage 2 is bidirectional Glenn, wherein the superior vena cava is connected to the pulmonary artery. And in those patients with bilateral superior vena cava, both the right and left SVCs are connected to the pulmonary arteries. In patients with interrupted IVC with azygous or hemiazygous continuation to the superior vena cava, Kawashima operation is performed. And following that, in stage 3, the hepatic veins are also baffled to the pulmonary arteries using a graft. The stage 3 palliation is what we call completion of total cavo-pulmonary connection, which is also known as Fontan surgery. This is done with or without fenestration. In our unit, we discuss each patient for the need of fenestration on a case-by-case basis. In few patients, we have also done Y-graft Fontan, but this is very rare. In our unit, the common practice is to do extracardiac Fontan. And in few patients with isomerism and abnormal lie of the heart, we have done intraatrial Fontan graft where the graft runs through the atrial mass. The atriopulmonary Fontan is no longer performed, and lateral tunnel we performed few years before, but we don't do currently. Comparison of the imaging modalities. As you all know, the common modalities we use in single ventricle are echocardiography, which is transthoracic, transesophageal, and 3D echo, cardiac MRI, CT, and catheterization. Echo is excellent for valve assessment, both for quantification and also understanding the mechanism of stenosis or regurgitation. Cardiac MRI is robust for function assessment, tissue characterization, and flow data. Cardiac MRI, CT, and cath can all provide anatomical information, but CT and catheterization will involve radiation and more so with cardiac cath. Cath will need general anesthesia in children. Cardiac MRI will also need general anesthesia in small children, but in our unit, most of the children more than 8 or 9 years of age, we do MRI without general anesthesia. CT less than 4 or 5 months age, we do feed and wrap, and 5 months to 2 years, we do under sedation using chloral hydrate. As you all know, the CAT can also provide hemodynamic data, and in single ventricle, we are particularly interested in mean PA pressure, transpulmonary gradient, and ventricular end diastolic volume. CT and cardiac cath are also useful for coronary artery imaging. Moving on to imaging before stage 1 palliation. The current evidence is very scant, but most of us will agree that echocardiogram is a powerful tool which will help us identify the sequential segmental anatomy and management can be based on that. We use other modalities mostly to confirm the echocardiogram findings, or if echocardiogram does not completely allow us to image all the structures. This is an active area of research. And in our unit, the current practice is imaging before stage 1 palliation. The echo is the only imaging modality in most of the patients. CT angiogram we do in some patients, especially to assess for a ductal stent, to study the ductal morphology. We routinely do CT angiogram in all patients with isomerism. And in patients with anomalous pulmonary veins, we do CT to confirm the echo findings, as sometimes there can be surprises. If pulmonary artery or arch anatomy is not clear on echo, then we go ahead with CT angiogram. Cardiac catheterization is very rarely performed. Can think of one instance where we have used in few patients in pulmonary atresia intact ventricular septum. If echo is suggestive of RV-dependent coronary circulation, we do cath to confirm this. MRI is very rarely used and for assessment of those patients with borderline ventricular volumes, for example, those with unbalanced AV septal defect and patients with borderline left ventricles. And the evidence for this comes from sick kids, wherein they have shown that if the LV end diastolic volume is more than 20 ml per meter square, these patients can undergo successful biventricular repair. They also use the flow data, the ascending aorta flow, to predict subsequent successful biventricular repair. Few examples where we have used CT angiogram before stage 1 palliation. This first patient is an unbalanced AVSD with pulmonary atresia. CT was done for ductal morphology. So you can see the duct coming up the undersurface of the arch with a straighter course, and this patient underwent successful ductal stent. The next patient is a very complex single ventricle patient where echo showed an unusual pulmonary venous anatomy, and hence we did CT angiogram, which showed a complex TAPVC where right upper pulmonary vein was draining into the left SVC through a ascending vein which was crossing the midline. And all other pulmonary veins drained below the diaphragm. There was an unusual communicating vein between the right upper and right lower pulmonary vein. This patient underwent a ductal stent as an initial procedure. As there was no evidence of pulmonary venous obstruction, the pulmonary veins were repaired at the time of Glenn at 3 months of age. Another patient where with isomerism, as I said, we routinely do CT for these patients. So patient had right atrial isomerism. The CT showed bilateral right atrial appendage morphology, and the pulmonary veins formed a confluence and drained into right-sided atrium, and the IVC drained into left-sided atrium. The ductal anatomy, as you can see, it has a very tortuous course. So this patient was considered not suitable for ductal stent, and hence underwent systemic to pulmonary artery shunt. So this patient had double inlet right ventricle. As you can see in the short axis view, the posterior left ventricle is hypoplastic. The arch anatomy was unusual in echocardiogram, and hence we did a CT. And you can see here, there's a rare association of double aortic arch in a setting of double inlet right ventricle. Moving on to imaging before stage 2 palliation. What is the current evidence? So this study from Great Ormond Street comparing cardiac MRI and echocardiography in 37 hypoplastic left heart patients before bidirectional Glenn showed that MRI does not add significantly more than echo if ventricular function is normal. The anatomical abnormalities detected by cardiac MRI can be imaged using CT without general anesthesia, and hence our practice is to usually use the CT. In next study, this study is from the Boston group comparing cath and cardiac MRI in 82 patients with similar baseline characteristic. They showed that there is no difference in immediate postoperative course between the two groups, and the clinical status or the frequency of reintervention at 3 months were also not different between the groups. Another retrospective review again from Boston group, which is a review of echo and cath data in single ventricle patient, showed no benefit of cath except for identifying anatomical abnormalities, which can be easily delineated using CT angiogram. So the current evidence is that there are only small studies that have shown that CT has high specificity and sensitivity as compared to surgical findings in patients undergoing stage 2 palliation, but there is no long-term outcome data is available. There's no study comparing CT and echocardiogram. And as I said before, MRI doesn't add anything if more than echo if ventricular function is normal. Cath hemodynamic data does not have any added benefit, and in our unit, we have not rejected any patient for bidirectional Glenn based on hemodynamic data. So the current practice prior to stage 2 in our unit is echocardiogram alone. In some patients, we always assess for the adequacy of atrial communication just to make sure that it is adequate. Otherwise, the patient undergoes atrial septectomy at the time of bidirectional Glenn. CT angiogram is routinely done for all patients with hypoplastic left heart and those single ventricle patients palliated with shunt and ductal stent. In PA banded patients, only if there are concerns on echo, we do CT angiogram. And if there is a question of rootability for achieving biventricular repair, we do CT angiogram. But if the question is both ventricular volumes, function, and rootability, then we use cardiac MRI. Cardiac cath is very rarely performed. In all our patients with hypoplast, we do echocardiography every week, and these patients spend interstage in the hospital. As you can see, this patient, over a time of monitoring, we notice that there's progressive tricuspid regurgitation and worsening of right ventricular systolic function. Few other examples. So the first figure, you can see the distal end of the sano insertion has caused left pulmonary artery origin stenosis. And commonly in the patients after Norwood sano, we see discrepancy in the size between the neo-aorta and arch size, which generally does not need any intervention. But if there is actual coarctation, we usually address that at the time of bidirectional Glenn, as any arch obstruction is, even if it is mild, it's poorly tolerated in patients undergoing single ventricle palliation. Another example where this is a pre-Glenn study for patient who had Norwood as a first palliation. As you can see, the CT clearly shows the Damascus-Stansel connection and the coronary artery filling very well. You can see the proximal sano connection here. The distal sano has caused some distortion of the pulmonary arteries. And also this patient has proximal RP hypoplasia, and this was addressed at the time of bidirectional Glenn. Another example where we used cardiac MRI prior to Glenn. This patient was assessed at the time of Glenn for a biventricular repair. Initially had aortic atresia and ventricular septal defect, underwent Norwood procedure. But since the LV volume was adequate in cardiac MRI, and also the VSD was thought to be adequate, this patient underwent a successful SOE repair. Moving on to imaging before stage 3 palliation. When it comes to investigation before Fontan, many centers, including ours, do cardiac cath. Is it really useful for management and outcome? Few studies are available to, kind of answer this question. So this retrospective study from Boston, including 175 patients, concluded that cath hemodynamic data was not associated with early postoperative outcomes. And also you must understand that there are risks of minor complications and very rare major complications. Having said that, 37% of patients required intervention, which is why we are finding it difficult to move from our current practice of doing cardiac cath before all our Fontan patients. This study concluded that 50% of the cath can be avoided with adequate non-invasive imaging, but they also concluded that echo alone is not sufficient. We have to do some other form of cross-sectional imaging, which is either CT or cardiac MRI. The same group from Boston, based on the results of the previous study, came up with this algorithm and tried to categorize the patient into high risk and low risk using this parameters described in this table based on history, echocardiography, and angiography. And if patients had one or more high risk categories, they did cardiac catheterization, and no high risk categories directly went for Fontan operation. Based on that, they identified 63% were low risk and 37% were high risk. And using they found that like nine patients out of 151 were inoperable after cardiac cath, and all the 9 were correctly classified as high risk by the algorithm. And this algorithm also predicted the adverse postoperative outcome with sensitivity of 51% and specificity of 78%. However, adding the hemodynamic data did not increase the sensitivity or specificity of this algorithm. So in summary, there's no significant correlation between pre-op hemodynamic data and short-term postoperative outcome has been described in the current literature. Hemodynamic data rarely changes the management strategy. Decision for cath should be based on clinical and non-invasive imaging findings. Cath for purpose of hemodynamic assessment alone may be avoided majority of patients presenting for Fontan completion. So current practice in our unit is echo for assessment of valve regurg, both degree and mechanism, and ventricular function. We do cardiac cath for most of the patients for anatomy, hemodynamic data, and interventions as required. But in the last 1 year, based on the high risk features, we have avoided doing cath in few of the patients, but most of the patients are still having cardiac cath. We commonly use combined imaging like MRI or CT doing at the time of cath. If the question, and also at the time of Fontan, we carefully assess these patients for either 1.5 ventricle or biventricular repair. So if the ventricular volume, function, and rootability is a question, we do MRI along with cath. And for assessment of rootability, we use 3D balance SSFP sequence. And if rootability alone is a question, we do CT at the time of cath. If there is a problem with the valve, we do transesophageal echo for assessment, and also we do 3D echo. And patients undergoing biventricular repair, we do TOE to make sure there is no AV valve straddling. Few examples. So this patient had an unusual anatomy, truncus arteriosus with hypoplastic left ventricle, had bidirectional Glenn before, and in the echo showed significantly impaired RV systolic function and moderate truncal valve regurgitation, and hence MRI was performed. You can see the MRI shows severe RV systolic dysfunction. The ejection fraction was only around 10 to 15%. And also there was moderate truncal valve regurgitation. So this patient was considered not suitable for Fontan and underwent a transplant. Another example, so this patient had right atrial isomerism, unbalanced AVST, pulmonary atresia with aorta coming off RV, post bidirectional Glenn. Echo showed moderate AV valve regurgitation. So MRI was performed for quantification of AV valve regurgitation and also for assessment of anatomy. So MR gave a regurg fraction of the AV valve of about 38%, which is moderate to severe. The AV valve was repaired at the time of bidirectional Glenn. And also, as you can see in this MR angiogram, this patient has pulmonary AV malformations in the right lower lobe, which correlated with the clinical finding of low saturation even after the Fontan procedure. Another example, when we assess for rootability at the time of Fontan to convert it into a biventricular repair, but this patient had a slightly borderline RV volumes on echo, so it was thought not to be suitable for biventricular repair. Hence, we did CT to assess for rootability as a convert into hemi-mustard with rasterly, which is 1.5 ventricle. The baseline anatomy was atrial situs inversus, AV discordance with VSD and pulmonary atresia, and aorta coming up the right ventricle, previously palliated with shunt and bilateral bidirectional Glenn. So the VSD was thought to be adequate in these MPR images for routing. Hence, this patient underwent rasterly, and the inferior vena cava and pulmonary veins were also baffled. So, which was a good outcome. The same patient showing the bilateral bidirectional Glenn and the branch pulmonary arteries. Imaging post-Fontan completion. So we monitor these patients with cross-sectional imaging as and when required. So generally our practice is to do cross-sectional imaging around 15, 16 years of age before transition to the adult care, or or earlier if there are concerns on the echocardiogram, we do MRI or CT. Mostly we do cardiac MRI because these children are old and we can do MRI without general anesthesia and we can avoid radiation. The patients who have Fontan failure, we generally do combined cardiac cath and MRI to get the hemodynamic data and also the assessment of function, as well as to identify any anatomical problems. So as you can see, these are patients who had TCPC, the CT angiogram and cardiac MRI. They provide excellent images. And here you can see the patient who had a intra-atrial graft Fontan, the Fontan graft running through the atrial mass. This is a 3D balanced SSFE image, which is excellent for evaluation of the entire TCPC. This patient had a protein losing enteropathy after Fontan and hence underwent cardiac cath and MRI to see if we can convert into 1.5 or biventricular repair. Baseline anatomy was double outlet right ventricle with transposed great arteries and pulmonary stenosis. The MRI RV endostolic volume was only 26 ml per meter square, which is significantly hypoplastic. And as you can see from the 3D balance SSFP images with MPR reconstruction, the VSD was thought to be slightly on the smaller side, and hence this patient underwent rasterly, but VSD had to be enlarged at the time of surgery. And as the RV was smaller, the Glenn was left alone. So in conclusion, multimodal imaging is needed for comprehensive management of complex single ventricle patients. Each modality has its merits and demerits. So based on the clinical information, the investigation has to be tailored for each patient. There is paucity of data to substantiate the role of cardiac cath prior to stage 3 palliation. And if adequate non-invasive imaging can be performed, can identify those patients who will need benefit from cardiac care. Combining imaging modalities can be very helpful, and multi-center randomized trials are needed to precisely identify the role of each modality in the interstage evaluation and also long-term follow-up. The future is most likely going to be combined X-ray and MRI lab, which is already there in few centers. That's it. Thank you so much for giving me this opportunity.